copy of I have a copy of that book if anyone is interested in looking at it. It's really quite amazing. And as those who have engaged in epidemiology know, and maybe microbiology as well, we have what are called the Koch's postulates for establishing causation. And it has helped launch a field of medical microbiology that continues to this day. In TB, 140 years later, we have a remarkable test for tuberculosis. We have medications to treat it. We even have medications to prevent it, yet it remains a leading cause of death and disability in the world today. In 1980, young faculty members around the US and Europe were engaged in research to try to understand why diabetics were particularly susceptible to TB. These were mostly immunologists trying to understand early immune responses to tuberculosis. In 1981, another disease came along called HIV and HIV/AIDS. And for the subsequent 30 years, all research seemed to focus on tuberculosis susceptibility, seemed to focus on HIV. And it's only recently that people have returned to the study of diabetes, metabolic disease, and tuberculosis. And today I'm pleased to introduce Dr. Matt Magee, who is taking the lead in studying the role of tuberculosis, diabetes, and metabolic diseases. Dr. Magee is an associate professor at the Hubert Department of Global Health at Rollins School of Public Health. He's also jointly appointed at the Department of Epidemiology in the Division of Infectious Diseases at Emory Medical School. Dr. Magee's work assesses the impact of tuberculosis infection and disease on metabolic disease risk. So we really are pleased to have you here today, Matt, and look forward to what you have to say. The floor is yours.
Thanks, Chris. Thanks, Julia and Chris, for the invitation to speak today. It's really my honor and pleasure to speak to you today. Also wanted to say thanks to the crew at Emory who's organized this, Sarah and Jenna and all the others who have put together all the hard work to organize this World TB Day Symposium. So to start off, most of my talk today is about tuberculosis and diabetes. The first two parts are going to focus on tuberculosis and diabetes. First, I'll speak about the relationship between diabetes and tuberculosis disease before speaking about diabetes and latent tuberculosis infection. And then in the last part, I'm excited to speak to you a little bit about the relationship between tuberculosis, undernutrition, and hyperglycemia, another emerging area of interest of mine. So to begin today's talk, I'd like to remind you of some worrying statistics about the burden of TB disease, some figures that you've probably likely seen today. And this is a slide that Cassie Bryan helped me create, which is demonstrating on the left-hand side the global burden of TB, and on the right-hand side is the global burden of diabetes. So we know 25% of the world is infected with TB, and there were over 1.5 million deaths due to TB last year, and that statistic continues. With regard to diabetes, globally 10% of adults are living with diabetes, and an additional 10% is pre-diabetic and at risk of developing diabetes. Importantly, most of the burdens of TB and diabetes occur in low and middle income countries. So the globe in the middle is attempting to demonstrate that the majority of TB and the majority of diabetes occurs in the same locations. So many of you are likely familiar with the natural history of TB and the concepts of exposure, infection, progression, and reactivation. As a framework for this talk, I think adding diabetes to this figure helps to visualize the different pathways by which diabetes can influence TB, and also to visualize the different ways TB may influence diabetes or hyperglycemia. So today we'll be discussing briefly nearly all of these pathways. So the title of today's talk included the clause disease interdependence across the lifespan. So one quick question is, what is a lifespan approach? Oh, I don't actually know the answer to that question, but I do think it's worth considering in the context of TB and diabetes. So a few ideas of how considering this lifespan approach to TB and diabetes may be useful. First, to recognize that we are susceptible and at risk of both diabetes and TB from birth to death. Throughout life, there are many dynamic changing factors which modify these risks, just to name a few: social determinants, epigenetics, genetics, and in the context of TB, perhaps the most important is just place and local transmission rates. However, when thinking about TB, I think it's most common to only focus on the most notable period, which is TB disease. But I do think it's also informative to conceptualize all stages of TB and to recognize the vast differences between individuals depending on when they become infected and progress to disease and recover from TB. So that's what these different bars are trying to demonstrate, is the vast differences in experience of TB across the life course and how from one individual could be very different from another. And then with respect to diabetes, also to recognize that once you develop diabetes, it's for almost everybody, it's a lifelong condition. Okay, so moving on to part one, I'll first review some broad information about the relationship between diabetes and its impact on TB disease. So when we think about the impact of diabetes on TB, I propose that this includes the cumulative impact of diabetes on all three of these blue pathways and the additional downstream impact of TB on TB outcomes. As a quick overview of the main themes in this part and this section, I'll present some evidence on these three main points regarding diabetes and TB. One, that diabetes increases the risk of TB disease. It's associated with immunopathy, and it increases the risk of poor treatment outcomes. Again, trying to relate the impact of diabetes on TB to the lifespan, I think the assumption of temporality is important to consider. So the overwhelming majority of type 2 diabetes cases begin in adulthood or even later in adulthood. Therefore, the impact of diabetes on TB risk would theoretically occur principally among adults after diabetes develops. And as I hope to convey in this talk, there's certainly sufficient evidence to suggest that the depicted temporal relationship exists, but there's also considerable additional information to suggest that this is not the only direction of the relationship that contributes to the overall relationship between diabetes and TB. Okay, so this slide is my attempt of a meta-analysis of meta-analyses. So there have now been several meta-analyses conducted to estimate the relationship between diabetes and TB incidence. So each one of these studies is a meta-analysis. Overall, patients with diabetes have approximately 2 to 3 times the incidence of TB compared to populations without diabetes. In addition, there's now substantial evidence that diabetes leads to immunopathy, which is a great term that was coined, to my knowledge, by Hardy Kornfeld, who's also a pioneer in the TB diabetes research community. He's a faculty member at the University of Massachusetts Medical School. He has both animal mice models as well as human studies. And in their early mice models of immunopathy, which he co-led with Nuria Martinez, they were informative to demonstrate that diabetes is associated with delayed macrophage activity in the lungs. As depicted in this figure, the recruitment of myeloid cells, which are in purple, to the MTB-infected macrophages in diabetic mice was significantly lower compared to controls. This impaired innate response is also mirrored in clinical responses in humans. Moving on to the clinical and epidemiologic findings related to diabetes impact on TB treatment, most studies demonstrate a reduced rate of culture conversion among patients with diabetes and TB compared to those with TB alone. So for example, a 2019 meta-analysis reported approximate doubling of odds of delayed conversion among patients with diabetes and TB. And as a specific example, this figure is from a study led by Argita, who is a recent epidemiology PhD graduate from Georgia State here in Atlanta. And this study of patients with TB from the state of Georgia suggested that the time to culture conversion was significantly longer in those with diabetes compared to patients with TB and no diabetes. Diabetes also, unfortunately, is associated with increased mortality rates during TB treatment. The odds of death among patients with TB and diabetes is roughly twice the odds of death among patients with TB and no diabetes. Several studies, including this study, cohort study from Taiwan, report, however, that metformin is helpful in reducing mortality in patients with TB and diabetes. So the left-hand Kaplan-Meier curve shows the increased survival in patients with TB and diabetes who did not use metformin compared to patients with TB and diabetes who did use metformin. And then on the right-hand side of the Kaplan-Meier curve, the same study showed that survival was similar in metformin-treated patients with TB and diabetes compared to patients with TB and no diabetes. Okay, moving on in part one, I'll now transition to a new directional relationship between TB disease and its potential impact on hyperglycemia and diabetes. So returning to our natural history conceptual framework, in this section of the talk, I will focus specifically on the dotted red arrow from TB to diabetes, so in the bottom right side there. Again, as an overview of the themes in this part of the talk, I'll highlight these three findings. First, TB impacts adipose tissue inflammation. Second, the prevalence of hyperglycemia at TB treatment initiation is high. And third, early data now suggests that transient hyperglycemia is likely associated with worse TB outcomes. So the idea that TB can induce hyperglycemia is not new. In this 2014 study using a guinea pig model developed by Brandon Podell and others at Colorado State University, they performed an oral glucose tolerance test on animals and then infected them with TB. And they showed that TB infection alone was sufficient to significantly decrease glucose control and clearance. A leading hypothesis regarding the mechanism behind TB stress hyperglycemia is that TB impacts adipocyte inflammation and metabolism. So recent mice studies, also by Hardy Kornfeld, and by another study by Stefan Kaufman's lab, demonstrated that after aerosol TB infection, visceral adipocytes produced localized pro-inflammatory signals, had reduced lipid metabolism, and became hypertrophic. Moving on to patient data related to stress hyperglycemia, this figure reports the proportion of all patients with TB and diabetes levels of hyperglycemia who received their first diabetes diagnosis at the time of TB. So across all these studies in these different countries, the red bar at the top represents the overall weighted average of approximately 22% of all TB diabetes patients are newly diagnosed at the time of TB. However, from this data, we cannot distinguish between those patients with previously undiagnosed diabetes and those experiencing stress hyperglycemia due to tuberculosis. This also does not include those experiencing hyperglycemia at pre-diabetic levels, which would likely include an even larger additional proportion of patients. So a key clinical concern is whether these patients should be treated for hyperglycemia with hypoglycemic agents. To date, there's very little data on the impact of stress hyperglycemia or transient hyperglycemia on TB outcomes. One cohort study published by Leo Martinez and colleagues, who I'm sure many of you know or have heard of as a graduate of UGA, assessed the association between transient hyperglycemia on TB treatment failure among drug-susceptible TB patients from China. And a key finding from this study was that the odds of TB treatment failure in patients with transient hyperglycemia was more than 4 times the odds of failure among patients with normal glycemic levels throughout TB treatment. So we know that stress hyperglycemia is common, and a high proportion of patients with diabetes range of hyperglycemia have not been previously diagnosed. As previously mentioned, we also know that from observational studies that metformin is associated with reduced TB mortality in patients with known diabetes. But we don't know whether a therapeutic intervention in those with newly diagnosed hyperglycemia would be efficacious. And in fact, some evidence suggests that tight glucose control, especially with insulin, is associated with higher risk of poor outcomes. This isn't among TB patients, but in this graph from a multi-center study of patients with stress hyperglycemia, they reported that tight glucose control was significantly related to increased risk of death and other complications. Okay, so a quick summary of the implications from part one. The negative role of diabetes on global TB control is now widely accepted. Given increasing prevalence of diabetes, this negative impact is only likely to expand. An emerging area of interest in TB diabetes is the impact of TB on hyperglycemia. And I believe the proportion of TB patients with hyperglycemia is underappreciated. And how to address this TB stress hyperglycemia is a critical gap in knowledge. And then last, relating back to the lifespan approach, in this section, we importantly did not discuss the impact of TB on metabolic health after TB cure. But we will discuss this a bit more in part three. Okay, transitioning to part two. In this section, I'll shift gears and discuss the potential bidirectional relationship between diabetes and latent TB infection. Revisiting for the last time the conceptual framework. In this section, in part two, I'll be focusing on these two arrows and questioning which of these arrows is responsible for the association between latent TB and diabetes. As a spoiler, it's probably both. Okay, to begin, from cross-sectional studies, we know that latent TB and diabetes are associated. On the left hand here are results from a study of recently arrived refugees to DeKalb County, Georgia. In this study, refugees received diabetes screening with a hemoglobin A1C and latent TB screening with QFT, quantiferin. The prevalence of latent infection among refugees with diabetes was 43% compared to 26% among those without diabetes. A similar trend and a dose-response relationship between prediabetes and diabetes with latent TB infection was also observed among adults from the NHANES study in the year 2011 and 2012. Also from cross-sectional analysis of NHANES data, we know that the association between diabetes and latent TB is different across racial and ethnic groups. In this study by Miriam Haddad, we see that the overall prevalence of TST positivity was 8% in those with diabetes versus 4% in those with euglycemia, or prevalence difference of 3.8%. However, much of the overall difference is actually driven by differences observed in Asian and Hispanic racial groups, and not so much among Black or whites. And we also have some preliminary data suggesting that the latent TB diabetes relationship differs by age. For example, this is data from an excellent cross-sectional study that Alison Smith presented this morning from Ethiopia. In this study of household and close contacts, the odds of latent TB infection in those with diabetes was 3 times the odds of latent infection in those without diabetes. However, when stratified by age, the association is largely driven by those older than 40 years. So as the previous slide suggested, the association between diabetes and latent TB is modified by race. These preliminary results also suggest that the association may be modified by age. A major limitation to much of the data on latent TB and diabetes is their cross-sectional nature. Clearly from the cross-sectional design, we can't distinguish which came first, latent TB or diabetes. And until recently, I think most assumed that like diabetes and tuberculosis disease, the diabetes likely increases the risk of latent TB. So what is shown now on the slide. However, an interest of mine has been to assess whether latent TB could increase the diabetes incidence. And a few reasons why I think this is worth considering. First, in the DeKalb County refugee study, the majority of the patients came from regions with very high TB burden. And given that the median age of the cohort was 40 years, it seems most likely that the majority of the patients were infected with latent TB prior to developing diabetes. Second, as discussed in part 1, we know that TB impacts adipose tissue inflammation, which also relates to the pathogenesis of diabetes, which in the context of obesity-induced diabetes is a pro-inflammatory immune response to expanding adipose tissue. Thus, there's plausibility that at least in some patients with latent TB who are on the higher end of activity end of the spectrum of latency, TB could contribute to ongoing adipose inflammation and influence diabetes risk. So based on that background and rationale, we were able to fund a small study to assess the relationship between latent TB infection and incident diabetes using data from the US Veterans Affairs Medical Centers. To briefly highlight these results, which were recently published, we used medical records, lab results, and prescription information to create a cohort of patients with known latent TB status who did not have diabetes and follow them forward in time to observe and compare incidence rates. So in this study, latent TB infection was documented by a laboratory result of either a TST or an IGRA. So we knew for sure that they had been tested for latent TB and had the result as either positive and negative. And then to assess the outcome of type 2 diabetes incidence, we included a combination of a prescription fill for diabetes medication and an ICD-9 code. This is an overview of who was included in the study. We included adults who had received at least one or more inpatient or outpatient visits at the VA Medical Center and had any test, either a TST or IGRA test during the study period. And that included 739,000 patients. We excluded those who had type 2 diabetes diagnosis before or on the date of an IGRA TST test, and excluded anybody who had a history of active tuberculosis. So in the end, we had over 574,000 participants, and of those, 6.6 were latently infected according to IGRA or TST. We ran multiple iterations of hazards model to compare the rate of diabetes incidence in patients with and without latent TB infection. In each model, as well as in sensitivity analyses, which were assessing multiple potential biases, we found that latent infection was associated with increased diabetes incidence. The best estimate from this study was that the diabetes increased the relative incidence by about 20%, as demonstrated here with the adjusted hazard ratio of 1.2. It's worth noting that in the same week that this study was published, a group of authors also reported almost the exact same hazard ratio in the exact same study question using the Swiss HIV cohort. So a different population because they were all HIV infected, but also looking at the incidence of diabetes in those with latent infection. Their adjusted hazard ratio was 1.4. So to recap some of the implications from part 2, I would like to suggest there's growing evidence to suggest a link between latent TB and diabetes. Importantly, even if a small proportion of the nearly 2 billion people infected with latent TB have even a moderate increased risk of diabetes, that equates to a large attributable population size for diabetes. Clearly, more work is needed to understand this relationship better. And just a few ideas for other studies on this topic include additional assessments among diverse cohorts, for example, by age, sex, and background TB transmission rates to understand sort of the effect measure modification that was observed in some of the preliminary cross-sectional studies. And as more momentum is being made towards scaling up latent TB treatment globally, I would also suggest that this provides a great opportunity to understand whether latent TB treatment could potentially mitigate any increased diabetes risk among those with TB infection. And then third, another unanswered question that I'm not aware of any studies that have addressed this is whether among those with prevalent diabetes, if co-occurring latent TB is associated with any diabetic complications or with glucose control. Finally, for part two, I'd like to think about the lifespan implications of latent TB infection and diabetes. So again, if latent TB infection influenced diabetes risks, that would likely begin early in adulthood for most people, at least globally, and may also later impact progression to TB disease. So again, just making things more complicated. All right, it's 4:30. Can you handle a part three? Are you guys up for part three? You ready to go home yet? All right, in this last part, I'd like to present some information on the combined impact of undernutrition and hyperglycemia on TB risk, TB outcomes, as well as post-TB health. So most of this, the audience here is probably well aware that undernutrition is a predominant risk factor for TB. On this graph on the right-hand side from WHO, we see a strong relationship between the proportion of a population with undernutrition and its TB incidence rate. A recent study that's now in press also estimated that up to 33% or 3.3 million TB cases each year are attributable to undernutrition. All this to be said, low BMI, which is a measure of undernutrition, is very important in terms of TB risk, as well as with increased risk of poor TB outcomes. Bringing hyperglycemia into this discussion, a few studies have now demonstrated that patients with hyperglycemia or diabetes and low BMI have the highest incidence of TB. So for example, in this study of 10 million people from Korea, the incidence of TB among those with diabetes and low BMI was more than 3 times the incidence of TB in those with normal BMI and normal glucose. So notably, this relationship is strongest in those with low BMI and diabetes than any other of the groups compared. A study led by Nan Cha, who is a current EIS officer at CDC, found a similar result in a cohort study of persons living with HIV from Myanmar. In this study, patients entering HIV care were screened for hyperglycemia and TB, and then followed prospectively and regularly during HIV care to screen for tuberculosis. And in this study, the highest incidence of TB was also amongst those with low BMI and hyperglycemia. And in an assessment of biologic interaction, we found that 23% of all incident TB disease was due to the synergy between hyperglycemia and low BMI. So as mentioned, low BMI is an established risk factor, not just for TB incidence, but also for poor outcomes. This is a study from Hardy Kornfeld's EDOT study, which took place in Chennai, India. And the main focus of that was looking at the relationship between diabetes and poor outcomes, but they also reported the highest TB treatment failure rates in those with low BMI. I was actually very surprised in the study to learn that 33% of patients with diabetes and TB had low BMI. When you think of somebody with diabetes, you don't necessarily think of them as having a low BMI, but over a third of patients with diabetes and TB in this study had low BMI. Another surprising finding from this analysis was that low BMI amongst those without diabetes had even higher TB treatment failure rates compared to those with TB and diabetes, just underscoring the negative impact of low BMI on poor TB outcomes. Okay, one last study to highlight before we conclude is the PIT study. This is an ongoing R21 study in Tbilisi, Georgia, with our colleagues at the National Center for TB and Lung Disease. This study is enrolling patients at the end of treatment and following them for 1 year after TB treatment ends. In this preliminary analysis led by Argita Salindri, we were surprised to find that 45% of patients had a sharp increase in their HbA1c only 6 months after TB treatment completion. So more than 45% had a 0.5 percentage points, which is actually quite large for the scale of hemoglobin A1c. The increase in A1c was observed in all BMI groups when BMI was measured at the end of treatment, with the larger increases in those who were under or overweight. And looking more at the preliminary results from the PIT study, we were also interested to know if the change in BMI during TB treatment was associated with the changes in HbA1c after treatment. So there's a lot going on with this slide. It's a little hard to follow. On the x-axis is the relative change in BMI during TB treatment, so comparing treatment start to treatment end. And on the y-axis is the change in the hemoglobin A1c after TB treatment, the first 6 months after TB treatment. And the regression lines are separated by those who were underweight at start of treatment, which is in red, versus not underweight in blue. So based on these preliminary results, I think the good news is that those who were underweight at the start of treatment and gained weight during treatment were not the ones who had the sharpest increases in HbA1c after TB treatment completion. So the implications for hyperglycemia and low BMI and the relationship with TB are vast, and I would say mostly unexplored. Given the high proportion of TB patients who are undernourished and the high proportion of those who are hyperglycemic, I do hope that addressing the synergy between these two factors provides an opportunity or will hopefully lead to improvements in some of our fundamental gaps in knowledge related to tuberculosis. Okay, just a few closing thoughts for today. I hope this talk has convinced some of you that diabetes impedes global TB disease control and that additional efforts are still needed to address many unanswered questions. Additionally, I believe there's mounting evidence to suggest that a TB-diabetes relationship is bidirectional and that we as a TB community should be expanding our attention to the metabolic impacts of TB. And last, I do think the lifespan framework is useful to consider, especially in the context of the World TB Day. I think the lifespan approach reminds me at least that as we are re-energized today, we should recommit ourselves to increasing our knowledge about and improving our actions for both or all three: TB prevention, treating TB, and then also trying to improve well-being amongst those who have survived TB. So the full spectrum of the pathogen. So that's all that I have for the formal part of the talk today. I'm looking forward to your questions. I would like to thank those who directly have contributed to this work. Here at Emory, there's a large group of people who have contributed to the slides that I created today, as well as colleagues at the University of Massachusetts, Hardy, of course, also at the University of St. George's in London, the many colleagues at our National Center for TB and Lung Disease in Tbilisi, who have contributed greatly to this work, as well as to CDC, Miriam and Nan, and of course to funding agencies. Thank you.
Thank you so much, Dr. Magee, for this excellent, very informative talk today. And I had sent you a hand clap. So for anyone else who would like to send a virtual hand clap,
Thank you.
Please join me in appreciating Dr. Magee for this excellent talk. And please let's open it up for comments, questions. Feel free to either raise your hand, write something in the chat, or go right ahead. So I'll just go by your first names if you don't mind. I'm reading the screen. Abdul, please go ahead.
Thank you very much. I'm from Emory Vaccine Center here in Atlanta. I have a question, clarification regarding metformin studies. Metformin appears to be having pleiotropic effects in multiple pathways and gut microbiome, cancer, anti-aging. So here you're just focusing on the reduction of glucose levels in the treatment. That is the one driving the TB infection, the low TB disease. What is that? What is the kind of mechanistic insight you have regarding the metformin studies?
Yeah, that's a great question. You know, I think there have been some animal models early on, also from Singapore, that also demonstrated an antibacterial effect of metformin.
Yeah.
So there's actually a trial, I believe, going on that also Hardy is involved with, in terms of a trial with metformin in people with TB, regardless of their hemoglobin A1C. So trying to use it as an adjunctive therapy for TB, regardless of, you know, diabetes status. I don't know more details about the mechanism between the role of metformin and its role in, you know, bacterial clearance beyond that.
So thank you. I'm just posting a paper just came out a few weeks ago. It must be important, maybe important for students. I'm just posting the chat.
Yeah, I'm sure there are others on this call who know more about that than I do. If they care,
it's not related to TB, but it's a kind of mechanistic aspects of metformin. I just posted that one. It could be maybe useful for students.
Thank you.
Thank you. Great.
Thank you. Chris, I think you're next.
Chris, I think you're on mute.
You're muted. You're still muted.
Yeah, unless you want to hear the dogs bark in the background. Thanks, Matt. That was really, really wonderful. I have lots of questions, but I will resist. And maybe ask two, if I may. One, it seems as though there's a lot of parallels with pregnancy with regard to some of the issues that are going on. And I don't know, there may be other medical conditions that disrupt the the glucose control and would be affected by tuberculosis too. And the second question I had relates to TNF alpha and, the low BMI and cachexia, the role that TNF plays in cachexia and diabetes. So you can answer either one or both.
Okay. Well, yeah, I agree that the analogy to gestational diabetes, for example, I think is a really strong one. That's actually something that Neil Gandhi also discussed with me, and we've used that a lot to try and explain the relationship between stress hyperglycemia and potential increased risk of post-TB diabetes. So, for example, women who have stress hyperglycemia or gestational diabetes, and after they give birth and they return to normal glucose levels, their incidence of diabetes is about 10 times those who did not have gestational diabetes. So I think that, in terms of understanding the role of stress hyperglycemia on the potential metabolic outcomes after TB, I think it's definitely something that we're sort of using as a model to try and understand that relationship. To follow patients after tuberculosis and understand whether or not those with stress hyperglycemia have increased risk of diabetes in a similar fashion. Because obviously some people who have TB could have had stress hyperglycemia for 2 years or, for the full duration of their disease, TB disease, which I think one estimated study by, I think it was David Dowdy, was that the average case of tuberculosis disease lasts for 2 years. That's just average from sort of the initial to the end phase. So regarding the TNF alpha, I guess I'm not sure I understood your question, or but I probably don't have an answer for it either way. So I don't know if you want to try and explain that more, or if others may have more insight into that than me also.
Yeah, I might defer to some of the immunologists who may be on the, but I was struck by that study where you looked at BMI, I think it was from Korea, that interestingly, people with low BMI had higher risk of TB and poorer outcomes, whereas people who had higher BMIs had a lower risk for tuberculosis than the euglycemic individuals. I mean,
right.
And TNF alpha is its other name is cachexin. So, you know, it's a key mechanism in causing consumption, the loss of body fat. And it just strikes me, I usually think of diabetes as insulin resistance among individuals with high adipose content, you know, percentage. But this is, you're presenting people with low body mass index. And so I'm just trying to understand why here they are diabetic, but they're thin. And others may have insight into that as well.
Yeah, I think a lot of it has to do with also the distribution of fat types, right? Like the visceral adiposity and versus subcutaneous adiposity. All of that, at least in terms of its relationship with TB outcomes, I think has a, you know, there's differences by the distribution of fat. And obviously there's different phenotypes, body types across the world. So I think, you know, all of this is just still emerging, but different relationships by body type. So.
Thank you.
Good.
Thank you.
Moving along, we have Dr. Castro.
Thanks, Juliet, and thanks, Matt. This was really a nice tour of the forest. A couple of questions that come to mind. In fact, one was more of a bit of a brainstorm. The calculations that you showed that plot the countries and the TB incidence by low BMI, that gives you the population attributable risk of tuberculosis associated with malnutrition, is a really rudimentary assessment, because it's strictly measuring BMI, you know, height and weight and nothing else. No, you know, the nutritionist in the group would have a hissy fit because there's no calipers used, no body fat, etc. And it occurs to me that, and the other part of what pikes this line of reasoning and thinking is something that I wasn't paying close attention to, the data that you highlighted, that even among those with low BMI, about 33% have abnormal glycosylated hemoglobin, showing that even with low body mass index, you have a third of these people have you know, demonstrable diabetes. And it occurs to me that we should try to chat with the folks at WHO who are implementing the TB prevalence surveys, because it would be fantastic to piggyback in at least one of these surveys a much more rigorous assessment of the metabolic nature of these individuals, you know, measure height, weight, calipers, and even get hemoglobin and A1C in a setting where you're drawing blood to test for HIV and doing other interventions. So you may want to park that there and use the next available opportunity with WHO to encourage them to consider studying this a bit further.
That's a great suggestion. Yep. Yeah, I like those ideas. I mean, I agree completely that just the BMI is a really poor indicator of undernutrition. I guess it's the most widely available and easy.
Right. I mean, it's the only, yeah. So then I don't mean to monopolize the questions. I see that Andy also has his hands up, but that there's a second question I have, and I may have asked this to you before, and maybe there's an update to that. In the mouse model where they these streptococcus induce diabetes, it is quite clearly demonstrable that when you do that and you induce diabetes in these mice, they are at high risk for tuberculosis, and that's been demonstrated. The question I've had is, has anyone assessed, what happens in these mice that you induce diabetes if you were to achieve euglycemia by treating them in the way we treat patients with diabetes? Would the risk of TB revert back to normal in that animal model if you were to metabolically achieve euglycemia by whatever drug you want to use, whether it's insulin, which is of course the most hormonally appropriate response to that. But are you aware of any experiments that look at, and I'm sorry that I'm repeating myself here.
Yeah, no,
yeah.
I'm sure Hardy and his team have looked at that. But yeah, I'm sorry, I don't know off the top of my head what the results were of those mice models studies were. But I can look into that for you for sure.
Okay.
Thanks, Ken.
Who's next? I see Dr. Banan. You please go ahead. You have your hand up.
Thanks very much. Very nice talk, Matt. I really want to just commend you for staying with this issue for long enough to finally get those of us who thought we understood things to realize that we don't understand them at all again. I relish every opportunity I get now to reiterate Jacques Grosset's wonderful comment that he would make repeatedly, saying, "I am so stupid."
Well, thanks.
Because I think this work has very nicely first compelled us to realize that our assumption that we understood the directionality of these effects was just entirely scientific hubris, and that we really don't understand what's going on here at all in many ways. Obviously, the idea that LTBI gives rise to risk of diabetes in some way, at one level strikes us all as a bit outlandish, and at another level, it's absolutely no surprise that a pathogen that's been associated with humans for millennia has discovered many different ways to accommodate itself, and we understand so few of them. One that has been occupying my attention recently because of my work with COVID now is the interplay between age and the underlying condition, which is very poorly captured in most of our models. In the first place, there's two different types of diabetes. In the second place, we rarely have knowledge about how long someone's had diabetes, but all of our prior assumptions were that the stage of progression and the tissue pathologies associated with longstanding diabetes were in some way related to some of these risks. So I'm wondering how you've been thinking about those, because the way we adjust for these things in most of our models seems woefully inadequate, given the complexity of the pathophysiologies in play.
Yeah, thanks, Andy. I appreciate the comments, and I appreciate your patience in listening to me talk about this so many times also. I know you were on the talk last week when we were at the CDC talk, and I actually think, the theoretical model of the sufficient component cause model is useful to think about that, because as you say, I think the age is a key component of that, and the age at which someone becomes infected with latent TB is probably one of the most important factors. Like, if latent TB contributes to diabetes risk, I think that person has to be, at the right stage, sort of ripe for it to have the impact and the underlying metabolic conditions in order for it to sort of take hold and potentially push somebody over the edge, so to speak, into diabetes. But unfortunately, from a analytic and like that's very theoretical, but when you try and put that into applied understanding and measurement, I think there's a real challenge because we don't ever know when somebody was truly infected with latent, there's no way to measure that. The only thing that I've been able to think about is that in terms of a design would be to conduct, look at people who are in household contact tracing studies, for example, in low incidence settings, potentially like the United States, and among younger people, so that if they are latently infected, you're almost sure that that was the first time that they were infected, and try and understand or observe if there are any sort of inflammatory or other markers of immune function dysfunction in adipose tissue right after that infection. Or you'd have to maybe potentially follow them for years and years and years. That's about as good as I've got for that. But I appreciate the comment. I think you're absolutely right.
Thank you.
So we have a few questions in the chat. I don't know if you've had a chance to look there. I know it's hard to multitask, answering questions and also looking and reading the chat. But I see that Susan Ray was asking about whether you have noted any concerns about the use of quinolones for TB treatment and the potential for dysglycemia in diabetic patients.
Yes, thanks, Susan, for that question. It's a great question. In my assessment of the literature, I have not seen that. I know that obviously quinolones do have a potential impact on glucose regulation, but I think it could go either way, hyper or hypoglycemic. But I haven't looked at it recently, but I was not aware of any studies that specifically looked at the use of quinolones in patients with TB.
Yeah, I think that's the reason I use dysglycemia, because it does go both up and down.
Yeah.
And Andy Vernon could probably school me on that because of the studies they've done at CDC and other places with quinolones and carefully evaluated, all kinds of parameters during the trial. But as quinolones become, even more prevalent in the use in TB treatment, because that new regimen, the four-month regimen, if we can ever afford it in the United States, we'll have more people on quinolones, and I wonder if we'll start to see some signals that are either good or bad. I don't know.
Andy, do you have any comments about that? Have you measured any change in glucose in the presence of quinolones?
We haven't, but we haven't looked a whole lot. Wendy might comment on this in terms of anything more recent that the Study 31 team has been looking at. They do have a relatively a somewhat weak indicator of diabetes early on. It wasn't a strong focus, but they were asked about either a hemoglobin A1C or a blood sugar or at baseline in the trial. So they do have some indication. And then there were people who developed diabetes during the trial, and we have PK, but and there is a control group who were not receiving a quinolone. So you might speak with the 31 group, either Wendy or Katya Korbatova, about looking in that data set a little bit more. I couldn't hold out a lot of hope initially, but the conversation would be worthwhile, and they might be interested in looking at more in the future. I don't know if Wendy wants to comment.
Any comments from Wendy?
Yeah, thanks, Andy. I don't think we have any results at this point in time, but I agree that it's an interesting thing to explore as we're continuing with the analyses.
Thanks, Wendy. So one more question I see in the chat says, does the or LTBI treatment regimen change when the patient is diabetic? And does it play a role in the association between TB and diabetes?
Thanks for that question. As far as I'm aware, and again, I'm not a clinician, I'm sure Susan and others have a better understanding, but I don't know of any altered TB or LTBI treatment regimen suggested changes in the context of diabetes. But Susan would, or others would speak
some
better.
clinicians will, I think in Virginia, Eric Haupt and others were for a while, and maybe still, empirically increasing the doses of meds because they were concerned, especially rifampin in patients with diabetes. That's the one, but not the choice of medicines.
Thank you. So I see we've come to almost the end of our time, and I wanted to ask a real, just clarifying question about the earlier slides that you showed. There was I think a result that showed that patients that had both TB and diabetes were 2 times more likely to die compared to those who had TB alone. Yeah, so I was curious about their HIV status. Was there any differences within the HIV status there?
Yeah, that's a great question. I don't know the details of that meta-analysis.
Okay. It would be interesting to know whether it's really the HIV or is it a interaction or
that's a
modification there. Yeah.
There have been very few studies that have looked at the interaction between HIV and diabetes and TB outcomes. I can give a little plug for some work of an MPH student at Emory right now, Kennedy, and she's working with Marcos and myself to look also at that specific question. We are underpowered, really. I mean, you would need a huge sample size to really assess that question, but using data from SENS, we will be trying to answer that question, looking at whether or not there's an interaction between HIV and diabetes with mortality or culture conversion. Sira also is working on that. Sira Chikayas, who's at the National Center for TB and Lung Disease. So.
Interesting. Thank you so much. So looks like we have exhausted all our comments and questions in the chat. And I see Chris's hand is up. One more comment and then we'll wrap it up.
Well, I just wanted to make the observation, it's come up several times, that I think we would be a lot further along in our understanding of the metabolic implications of TB had HIV not come along. Because truly that was the focus of research circa 1980 on TB and diabetes. And, given the urgency of the time and the day, but it really did take a long time for us to work through. And I don't know whether there's something to take away from that as we encounter epidemics and, we all jump to solve problems. Maybe some problems need consistent work over, so we don't lose 30 years. So.
Yeah, no, I appreciate that, Chris, and I learned that from you. It's a helpful lesson to keep in mind. And in some ways, I also see parallels to sort of the role of undernutrition and TB with similar to like TB and diabetes. Like it feels that undernutrition has also been ignored. It's a relationship that has been known for, centuries, and yet we've made such little progress in terms of understanding how to address undernutrition and TB, both in terms of TB risk and TB outcomes.
Yeah. Well, nice work. Thank you, Matt.
Thanks again for the invitation, Chris and Juliet.
Yeah,
and thanks everybody for attending.
Right. I'm just going to give a chance to Ankita because I see she has a hand up. I'm going to give you half a second maybe to
sure, yeah.
ask a question and then we'll wrap it up there.
Thank you. Yeah, great talk, Matt. And actually, Chris made me excited to talk about it when he talked about HIV. So I was just wondering, because HIV is associated with a lot of dyslipidemia because of various reasons. So do you think that could be one of the potential reasons for increased risk of TB in these individuals?
In individuals with diabetes?
HIV, in
Oh,
HIV
HIV.
infected, even who are people living with HIV on treatments?
Yeah. I don't know. That's a good question. I'm sorry, I don't really have any information about dyslipidemia in the context of TB risk. Yeah, but that's a good question for sure.
Okay, thank you.
Okay, so with that, I would like to thank Dr. Magee for just such an excellent talk and very informative. And we would like also to thank our audience from all around, and please come again. We have these seminars once a month. And so thank you again for being a part of this. Very, very exciting.
And Juliet, I don't want to miss the opportunity to say that this may be an inaugural seminar for the Emory, Georgia TB Center, since it was awarded yesterday. So,
oh, yes. Yes, that's
yeah,
right.
and being part of the World TB Day activities of Emory, UGA. There were some earlier today in Uganda. So it's a good kickoff for the center.
That's right. Thank you, Chris. And with that, everyone, thank you, and we'll see you next time.